Okay, so as I mentioned, one of our last tasks second to the last tasks in looking at different psychological disorders is looking at psychotic disorders, or what is psychosis, as you would say. And um, really, the difficulty of saying what a psychotic disorder is that it makes sense when a person has a disconnect from reality. So you think about someone who has a delusion that they're the president of the United States, or Gandhi, or Jesus Christ. That's obviously kind of a break from reality. Or you think of someone who has hallucinations of voices in their head, and no one else can hear those voices or not. And you think of that from a kind of a purist perspective, that makes sense. The thing that I want to be careful of is dependent upon the symptomology of the individual. Remember, with the DSM, we went into what's called spectrum disorders, where there's mild symptomology, where it's easy for the individual to identify their symptomology and recognize that it's a break from reality, versus people who get more on the extreme end of a psychotic disorder, where their reality is the delusions, the hallucinations, that is their reality. Um, and it's hard sometimes then to break the difference between what is someone's reality versus what is this disorder that they're experiencing. Okay. And so that's why I'm kind of being cautious about breaking stating the line that this is a break from reality, because in many individuals' lives that suffer from schizophrenia and stuff like that, that is their reality, um, and whatnot. The disorder that is most commonly associated with psychotic disorders is schizophrenia. Okay. And a related disorder called schizoaffective disorder, which we'll get to here in just a minute. Um, but there are other types of psychotic breaks that a person can go through. Someone who goes through a severe trauma can have moments of psychosis. People who have what are called dissociative disorders, which we will get to when we get to the personality section, where they create a whole new entire life for themselves, completely disassociated from their reality. Um, but schizophrenia tends to be that disorder which kind of exemplifies the extreme levels of how psychosis can go. There is one other piece of caution that I do want to provide when dealing with psychotic disorders, is that um, many people who suffer from psychosis suffer from what's called drug-induced psychosis. So things like methamphetamine, extreme alcoholism, cocaine use, opioid use, all of those, when taken in a sufficient amount of quantity, can create disconnects from reality, where a person can get into delusional or paranoid thinking. They can have extreme hallucinations. And I'm going to say this, they're not always pleasant, just to kind of put that out there. Um, but just some, but I just want to amplify the first thing that needs to be ruled out whenever diagnosing or assessing someone who is having a psychotic break is substance use. Because there's a lot of individuals who are, for example, in prison, who have a diagnosis of schizophrenia, but they don't have schizophrenia. Their delusions were their psychotic breaks were due to some type of drug or substance use. Okay, so I just want to make that differentiation as well. But let me go through and kind of give again that Western clinical diagnosis of what schizophrenia is. And I would actually encourage you, because we're going to watch a video of Bob, who has an extreme level of schizophrenia. He's really on the dysfunctional end of the spectrum. Um, and he has all five of these symptoms. But these in this A area, this is the first kind of criterion. So, for example, the first one is delusional thinking. This can be anywhere from thinking that a person is Gandhi to the government is invading us through little green ants that come into our homes at night. Um, to simple delusions on the mild end, that people are after you, that people are trying to attack you, or this common kind of feeling that there's something coming after you. Okay. Hallucinations are, again, and I'll bring this back to Psych 101. We all hallucinate. Um, we will all have auditory, visual, kinesthetic, and smell hallucinations, and that's not uncommon. But with schizophrenia, those hallucinations are constantly there. Okay. And again, we're going to go back to this video of Bob. He has auditory hallucinations. And this is one way that you can tell the difference between someone who has schizophrenia versus someone who has substance abuse induced psychosis. Okay. If you were to ask me, Dr. Peterson, I want to live in the safest place possible, where I reduce the risk of being violently assaulted by someone. I would tell you to go live in a residential home or a halfway home that caters to the treatment of schizophrenia. Okay, because the auditory hallucination that schizophrenics have tend to be about self-harm. They tend to be about you're worthless, you're not worthy of anything, you're not this. Individuals who have substance abuse hallucinations or auditory hallucinations tend to have hallucinations about harming someone else. And indeed, you have a less chance of being assaulted by someone who has schizophrenia than you are by your own next door neighbor, because they are so focused on they're worthless and they're not worthy of anything. They're not thinking about harming other people. Okay. And so I just wanted to mention that on auditory hallucination. It's a very common. Probably the most common hallucination is actually olfactory or smell. Um, and that's one of the more common hallucinations, especially when we look at people with mild versions of schizophrenia. Now, I will say, I always say this in these classes, is if you smell bacon without the presence of bacon, please don't think you're contracting schizophrenia. Get to the hospital, because more likely you're having an aneurysm in your brain. For some reason, one of the symptoms of an aneurysm is the hallucination of the smell of bacon. Kind of a strange thing, but just kind of a little warning sign out there. Um, Another common hallucination is kinesthetic, meaning feeling like you're being touched constantly, and feeling pressure on the skin. And so visual hallucinations are actually the more rare hallucinations. It's really people who have a moderate to severe schizophrenia that have visual hallucinations. Okay. The third one is disorganized speech. You will definitely hear this with the video of Bob. I'm going to ask you if you can follow one of his stories from from beginning to end and make a logical story out of it. We need to talk after class. No, I'm kidding. I just want you to listen to his stories and how disorganized his speeches are. He goes from one topic to the next. To him, it makes complete sense what he's saying, but to everyone else, it's very, again, disorganized. Grossly disorganized or catatonic states. So this is again dealing with people who have moderate to severe schizophrenia. You can have this grossly disorganized kind of behavior. So you will notice again with a video of Bob, he will have one cigarette in one hand, he'll be lighting another cigarette, he'll be packing a cigarette pack uh, as well. So he'll be basically almost look like he's trying to smoke 3 cigarettes at once. Okay. This is what we call grossly disorganized behavior. Okay. A catatonic state is something that hasn't been well explained in the literature. We still don't know what causes a person to go into a catatonic state. We think it has to do with extreme stress combined with a moderate to severe schizophrenia. And that extreme stress makes a person go into a catatonic state. But what catatonia is on the severe level, if you've ever been to a plastic museum, a statue plastic museum, you understand what catatonia looks like. It's like the person is almost frozen in time. Okay. Now, they still have normal brain functioning, they still have breath. On severe levels, they might have to give some breathing assistance, but on the most part, they still have their bodily functions, but it's almost like they are completely frozen in time. And I remember in my undergraduate years, we went and did some work for a inpatient center, and literally someone in a catatonic state, they could have their arm out, and if you push their arm down, once you release it, it will go right back to that same space that it was originally. um, and so that's catatonic. The current theory behind it is it's an extreme stress response combined with all of these other symptoms that the person has. Okay. Negative symptoms, if you want to think about negative symptoms with schizophrenia, it's when a person has a very flat affect. You'll notice with Bob, you really can't tell whether he's happy, sad, glad. Sometimes he has a small elevated mood. You'll notice when he goes to the mall, for example, he has more of an elevated mood than when he's at home. But for the most part, it's a very flat affect. Okay. Now, this second criteria is where we again look at the disturbance, the level of functioning, whether it's someone who has a mild, so they can still continue to work and take care of themselves, or severe, where they become completely have the complete inability to care for themselves. But there are some have argued 2 types of schizophrenia. Okay. One is called functional schizophrenia, and the other one is called non-functional schizophrenia. Okay. And it very much seems to deal with the time of onset of the schizophrenic symptoms. Okay. The majority of schizophrenics get their symptoms when they first leave their home, when they become from going from an adolescence to a young adult. Indeed, when I ran a behavioral health center for a college, about 3/4 of the way through fall semester, I always kept some slots open because I would always have some dorm students come over and complain about seeing things that no one else is seeing. They feel like they're going crazy. They feel like people are following them. They feel like They can't get any work done anymore. And usually it was the early signs of late onset schizophrenia. Okay. Late onset schizophrenia is normally associated with what will develop as non-functional schizophrenia, meaning that if those symptoms are not treated early on the onset, these are the individuals who end up having to live in an assisted care unit, inpatient unit, those types of places. Functional schizophrenics are people who we actually think that their symptoms started from birth. And the difference, though, is that they went through all of their developmental periods, early childhood, late childhood, and into adolescence, with their symptoms and learning to cope with their symptoms as they were developing. So these individuals tend to get into adulthood and tend to be able to hold their own job, be able to live on their own, tend to be able to have relationships and those types of things, despite the symptoms that they have. Okay, so that's this level of schizophrenia. Now, I do, it would, these are just the same as others. So again, we have to rule out bipolar, schizoaffective disorder, which we'll get to. Again, you'll notice on here that we got to rule out things like autism, especially when it comes to late onset autism. One of the big differentiations, if you've heard, we've had this this sudden increase in the number of people who are diagnosed with autism. And just so you know, I fit with the American Psychological Association, and it has to do with better diagnosis and better awareness of the disorder. Because for the majority of adults who have autism and they weren't diagnosed as children, back 10, 15, 20 years ago, they tended to end up with a diagnosis of schizophrenia. But what has changed with our knowledge about autism and schizophrenia is we've gotten a lot better at diagnosing the difference between someone who has a psychotic disorder versus someone who has the social disorder of autism. So that's another rule out that we have to do before we diagnose someone with schizophrenia. Okay. Now, I would be remiss by mentioning schizoaffective disorder, because this is also what we call a rule out diagnosis for the disorder of schizophrenia. Okay. People who have a severe mood disorder, so severe major depression, severe manic outbreaks, can also start to develop delusions and hallucinations. Okay. For 2 or more weeks during their major depressive or manic episode. Okay. This usually has to do with the neurochemicals that are associated with that mood disorder, such as serotonin and dopamine. But we do have to, before we say you have schizophrenia, we have to rule out that they might be suffering from a major mood disorder, such as depression or mania. Okay. The reason that is because for a person who is having delusions and hallucinations while in major depressive disorders, your treatment will be different. You want to treat the depression, not the delusions and hallucinations. If you treat the depression and the mania, the delusions and hallucinations will go away. And so instead of going to an antipsychotic medication, you want to go to a mood stabilizer or a medication for depression or anxiety. Okay. And then, of course, again, we have to rule out for substance use. Okay. So that's schizoaffective. And it's important to kind of keep that in mind, especially if you have someone who in your life that has major depressive disorder or has bipolar disorder, that if they start experiencing that, it's a bad idea to go down the psychosis rail. What way? It's better to try and help them get stabilized for their mood disorder. Okay. All right. All right. So I'm going to go back to here real quick, and we're going to watch this video of Bob. And again, I want you to try and figure out these five symptoms in Bob and recognize. Yeah, Kara, you have your hand up before we go on.
Yes, so I actually am dealing with a schizoaffective disorder person that I didn't feel was have that, but I just found out his diagnosis. He just turned 18. I found him on the street, and he is not on his medication. And I did send him to a transitional residential treatment facility, and they had to ask him to to go. They tried to recommend an evaluation, but he didn't want to go. And he hasn't been on his medication. He confessed to me that he hasn't been taking it. So is that where the violent part comes in? Because he got in like 2, 3 fights already
Yeah,
without his medication.
and Kara, that's a very good point as well, and thank you for bringing that up. Is that schizoaffective individuals may aggress towards other people. Someone with schizophrenia tends to do self-harm, where schizoaffective, because they're so frustrated by their symptomologies, can act out. So that's another kind of differentiation, and that's a wonderful example.
Okay, yeah, I just wanted to ask, and now he listens to me, so I'm able to calm him down, and he is in the process of getting the right help because he needs to be evaluated. He's been without his medication for almost 3 weeks. He confessed, so it's
Excellent.
like, okay, thank you for, and keeping him calm wasn't hard for me, but I think it's just like my whole just how I am, you know? So he's
Mm.
willing to be open. I was grateful for that. And I was like, I was at some moments, like, I hope you don't snap on me, you know? But yeah, he's on his way to get help. And I was glad he was able to agree with me. And it's really crazy that we're talking about this because I was having questions and I was looking through my book and what am I supposed to? Because I don't want to leave him, you know, like I know there's help, you know, and he just doesn't know how to ask for that but thank you, Dr. Peterson.
Excellent. Thank you for bringing that up. That's a great example of these differentiations and whatnot, and a great example of a case study, as you would say. So thank you for sharing. All right. So as I mentioned, so with Bob, he doesn't go into a catatonic state, but I'd like you to recognize his grossly disorganized behaviors. Okay. So see if you can pick these up, and then we'll have a conversation about it when the video is complete. So let me mute.
Years and 6 months, respectively. This is a new bike. Dad tried to sway my eyes when I was depressed. Tried to put a bike in here so we could get some life, you know. And this is a radio, cigarette case, and the holder in ashtray, and this is a TV.
Could you tell me about the trophies? Are those things you've won?
I was an excellent bowler and a Latin scholar in high school and college. This I got from Nelson Burton Jr., an average of 195 in bowling. This was from the Forensic League. Seal of approval.
Bob was once the captain of his high school's debating team. He now experiences extreme thought disorder and talks in a disconnected jumble of words.
I know how to angle myself with the rest of the men, do you see? That's why I did that to Sue. That's why I did that to Aunt Ethel, you know. And I wanted Fritz and all of them to know, the praying mantis and the spider and the grasshopper, to know that I think it's very important that we act badly, but I think it's very important that we act in reality of what makes the world go round. You know, you're liable to go sliding off the curb into your death on a man that can't control himself. So really, the endless wins, whether it's no or yes. So I think bulk sometimes wins. In some of the cases, you know, the very agile cases, the bulk wins. But I think the most important thing the devil can do is to self-sacrifice and coordinate the Kmart walk so pleasure can be evened out. And in fact, I've really swayed my charms towards going forward into straighthood. But I think every doctor knows if there's no such thing to believe in straighthood and to go ahead forward into kidney stones and stuff like that, you know, Dad's a son of a bitch. But
Bob, do you know how long you've been sick?
about a year.
Just recently?
No, it's been about a year and 2 months.
Bob doesn't realize he's been sick for 17 years.
Could you give us a little bit of a description of what Bob was like as he was growing up?
Yes, Bob was a very serious person from the first day he was born. We thought surely he was happy. He had just about everything. We spent a lot of time with him, and we loved him very much. This was our first child, and we had a lot of hopes and expectations of Bob, because he was a very smart fella, and his coordination was great in sports. He liked government affairs, he liked politics and the like. As I say, he excelled in math. He had 4 years of math in high school. He accepted the responsibilities of his homework on his own and did a bang-up job. He was an all-American boy.
On the advice of a private psychiatrist, he said that he felt like he needed...
In the beginning of Bob's illness, doctors advised his parents to commit their son to a state institution.
I think that
Bob's mother talks about why she decided instead to take care of Bob at home.
He was in that state hospital for 6 months. And it was just terrible to see what happened to him. And when I saw him, I couldn't believe that this could happen to this kid that had been such a great kid. He was he was so thin, he could hardly keep his shoes on. He shuffled, he could hardly walk. And he was just so drugged.
You just had to take him by his hand, you know, and lead him.
And
he was that bad off.
like a little puppy or something. It was terrible. And I said to Cappy, I'll see this child dead before I'll ever let anybody do anything like this to him again. And we brought him home.
You won't have to have a second piece. Yeah.
Bob, do you want to return thanks for us this evening? Okay.
Our dear precious London town man, we pray that you will please forgive the sins of the states and take us to the lasagna dinner. We pray that you will bless our loved ones for hearing and seeing and smelling purposes. We pray that you will also let us go east, and we ask these things in Christ, the Messiah's name, and for his sake. Amen.
Okay.
After dinner, Bob's mother, Frankie, talked about her son's childhood and how he first got sick.
I hope it is.
Bob's was a typical case. Schizophrenia struck him at age 18, during his first year of college.
And it came on suddenly. It was, he was in college, and we really didn't recognize it. He came home at Thanksgiving, his first semester in college, and he was nervous, but we figured, you know, it's just college. And then when he came home at Christmas, he was kind of pacing and walking the floor, and we still didn't recognize anything, just thought he was eager to get back to school. And by mid-semester exams in January, he was calling home 2 and 3 times a week, a little before that. And then he got to where he was calling home 2 or 3 times a day, and then 4 and 5 times a day, and then in the middle of the night he'd call and talk an hour, always to be reassured. And we could not understand this. We just didn't know what was happening. And finally, on Thursday, before his final exam started on the following Monday, he called and he said, Mom, my mind is going. I'm losing my mind.
Are there some things you'd like to do?
Yeah,
What would you like to do?
most of anything. I'd like to, I was going to say screw them. Be with the Cowardly Lion.
In the following September, he was hospitalized for the first time. He was in a private hospital, and he was in there for about 5 weeks. And that's when they started giving him Haldol. And then we saw the reports at the plant where my husband works, and that's when we found out what he had, was through the insurance papers, and on there it said acute schizophrenia. And we didn't even know what schizophrenia was. Well, of course, now we know it is a disease, but back in those days we didn't know this. And that's very hard on the parents when they learn, when you have a doctor telling you because of something you did that child is ill, and it's not true.
Scientists and doctors do not know what causes schizophrenia.
Is an encephalogram.
There are several theories for the onset of the illness. Schizophrenia often runs in families, and it may be inherited genetically. Yet, as in Bob's case, there is no history of mental illness on either side of the family.
I think those bats and the witch and Cliff were really my father, but the Tin Man wouldn't let me date my father. Too big, you know.
Some scientists believe in biochemical theories, that there is something wrong in the metabolism of the brain.
So, I think the monkeys and the men are mixed.
Some doctors believe that viruses attack the brain, possibly during the pregnancy. Abnormalities in a person's immune system, developmental theories of early brain damage, even stress theories in which a person goes mad because he cannot cope with the pressures of his life. But all of these are just theories. Schizophrenia is not curable because no one really understands what causes the illness.
I think we need to fly over the Atlantic Ocean. That's what we need, yeah.
You feel more like doing something?
Oh, yeah.
Bob's father, Cappy, decided to retire early to devote more time to his son's care.
But I think as time goes on, it's smart to lay off medicine.
You don't like to take the pills? You think you could ever get much better if you don't take medicine?
It just depends on how I could hit the golf ball.
One of Bob's symptoms is the need to walk, to release his excess energy. Bob once walked out the door of his home in West Virginia and was found by the police several days later. He had walked all the way to New Jersey. And so every day, 3 times a day, Cappy drives his son to a shopping mall. The Kmart is Bob's favorite place to go.
Hi.
Oh, Bob.
Yeah.
Are you just walking, or are you?
You know,
Shopping.
I just love to shop.
Don't let us hold you up.
As Bob walks, he constantly hears imaginary voices, perhaps the most dramatic symptom of schizophrenia. He hears these voices as clearly as he hears the voices of real people talking to him.
Are you going to still stay around here? Want some hot chocolate?
Bob can't control or stop these voices, which always torment and criticize him.
So how you feeling, Bob?
I just had to claim life.
What's that?
Had to claim life.
Claim life.
Yeah.
What do you mean by that?
You said that I have never been a man in my life, therefore I have to
Oh,
claim
no,
life.
I didn't
Yeah.
say that.
Oh, okay.
I wouldn't say that.
Okay.
You'll be a man.
You'll be a man someday.
Bob is one of the 40% of schizophrenics that don't respond to any drug treatment. He's been given Thorazine, Stelazine, Haldol, Moban, L'Occitane, Prolixin, Meloril, and Navane. But none of these antipsychotic drugs have made Bob any better.
Always healthy to buy practice.
Bob is about to start taking an experimental new drug called clozapine. It's considered a last hope medication for schizophrenics who have failed to improve on all other drugs. But there is some risk in taking clozapine. The medication can, in some cases, have dangerous and even fatal side effects.
We want it to work so badly, but yet you always have to remember it may not help Bob, it may not help Bob, or he might develop the side effect and not be able to take the medication. If he can just be happy and have an attitude of just wanting to do something or wanting to go to school or even being able to watch television or just be better than he is, you know. This is just a wasted life. It's not only wasting his life, it's wasting ours.
I don't know. I just have a feeling about this one thing that it's going to help. It's got to help.
We can't imagine waking up in the morning and not having this sick kid. I just can't imagine what it would be like. So we are really looking forward to it. It's hope. It's a lot of hope. And
Bob didn't get better. His thinking started to improve, but he had a bad reaction to clozapine and had to stop taking it. Bob lost his balance and coordination, and today cannot stand up or walk. After struggling with the illness for 17 years, Bob's mother and father finally decided to commit their son to a small group home, where Bob will receive the intensive care he needs.
Oh, right. So that's the story of Bob. And I just wanted to talk about a few things to note. You heard that about 40% of schizophrenics do not respond to excuse me, drug treatment, and that is still current. I think we're doing a little bit better, like around 32% is the number now, but we're still having difficult time really with a percentage of people with schizophrenia and using the biological or medical methods. Now, something to note about antipsychotic medications is that their mechanism is to decrease dopamine and acetaminophen in the person's brain, because schizophrenia is associated with elevated levels of dopamine and acetylcholine. Okay, and you note that Bob's bad reaction is he lost the ability to walk and lost the ability to coordinate movement, because the side effects for antipsychotic medication are actually Parkinson's symptoms, because Parkinson's is associated with an underdevelopment of acetylcholine and dopamine. And so the side effects for antipsychotic medications tend to be Parkinson's types of side effects. The side effects for Parkinson's medications tends to be schizophrenic symptoms. So that is really when a family is making a decision about the treatment or medical treatment of the disorder through medication, those are some of the risks that have to be weighed for a lot of these families. I will tell you, Bob actually didn't live very long in the halfway house. He actually passed away because of those reactions that he had. To those medications. So it is a very tight line, but it also goes back to the reason we need to make sure to differentiate the difference between schizoaffective versus schizophrenia, because if we can treat the mood disorder that is giving away to delusions and hallucinations, that's much safer than putting the person on an antipsychotic medication. Okay. And so just to go through some of the things that you'll noted is his delusional thinking had a lot to do with self-harm. If you notice, he went into a kind of a fantasy world about the devil coordinating the Kmart walk so well, about being able to get off medication if he can hit a golf ball right. They gave a clear example of the hallucinations, which were auditory for him. And then I hope that you saw the disorganized speech and the inability to have a coherent storyline. Okay. And then, of course, his gross disorganization and his negative symptoms. There was one other thing I wanted to say about Dear Bob. One thing that I should note, and it is important to kind of bring to volition, is throughout these disorders, we've been talking about medications, and also there's psychotherapy, there's behavioral treatments. I will say that this is like a lot of the other disorders. The most beneficial treatment is a combination of behavioral therapy and medication. That tends to be the most effective. Just like with depression, you usually do some cognitive behavioral therapy with medication, and that tends to increase the efficacy of treatment. And so I do want to mention that yet while it is tightly biologically bound, just like a lot of physical illnesses, there are things that the individual can do to help manage their symptoms as well. Just like with, when you think about diabetes and regulating sugar intake, schizophrenia, there are some behavioral therapies that can help you manage the onset of symptomology. So I did want to bring that up because this isn't just a medical thing and it's done and there's nothing a person can do about it. There are different other treatments that are effective as well. Okay, is there any questions in regards to this disorder?
Yes, I do have a question. Hello? Can you hear me?
Yeah.
Okay. So, like what you're talking about, like all the medications and stuff. So, for his diagnosis, will it affect him like with metmorphin, Ozempic, and the dopamine along with his schizophrenia medication? With I think he has the aneurysm as well.
Yeah. Well, I'm not sure how it interacts with those Ozempic and those because those are
Diabetic. I mean, I was just asking because you know how sometimes metformin can make some people what do you call it? Not sick or dizzy sometimes. And then his medication, and then not only that, like with the Ozempic, he did share that when he started it, he would throw up. He hasn't been wait. He's been on it for a while.
well, and again, this is an academic conversation. There has been in the last about 15 years some research that has done research on stomach metabolization and schizophrenia that does show that imbalances within the digestive symptom tend to be associated with schizophrenic symptomology. But with that being said, and this is the warning sign behind that, is it's also associated with depression and anxiety and
Yeah.
PTSD and all those. So it's hard to say what necessarily the roles though will play as far as the symptomology, but there is this growing evidence that yes, anything dealing with your digestive symptoms will play a role in your experience of depression or anxiety or schizophrenia or the likes. So if that makes sense.
Okay, yeah, it does. It totally makes sense. Yeah, I've seen it before, so that's why I wanted to ask again. All right, thank you so much, Dr. Peterson.
You're welcome. Leanna, you have your hand up.
So, like people who have a heavy drug use, does it like onset if they never had schizophrenia? Like I had a conversation with someone about like nowadays with marijuana, like the synthetic marijuana could trigger like schizophrenia or some type of like in your brain. I don't know if that's true, but so someone was telling me about, and I was really interested about it. Or is it like, yeah, because I don't understand how they get it. I know, and it's like genetically too. So I don't know.
And it's so if we go back to the substance use type thing, so marijuana is a hallucinogenic, but it is not everybody. Unlike if we're doing LSD or cocaine or something like that, it doesn't mean that everyone will have hallucinations while smoking weed. There is some evidence. I haven't seen replications on these kind of studies, so I don't really want to promote it, suggesting that the more synthetic type of marijuanas are more associated with hallucinations and those kinds of things. I'm kind of cautious about that because I haven't seen a lot of replication of those studies. Um, but one of the issues that you have when you're dealing with something like a hallucinogen and marijuana is its ability to stay within the system for an extended period of time. So, for example, alcohol will stay in the system from anywhere from about 12 to 48 hours. It usually is completely out of the system within 7 days, hence, detox is usually 5 days. Things like cocaine are in the system for only hours, and those kinds of things. But when we're dealing with drugs such as marijuana, they can stay in the body system for anywhere up to 30 to 45 days. And so a person who has sensitivity to that drug with hallucinations can continue to have hallucinations well up into 40, 45 days post taking that drug. Okay. And that's kind of with the studies on marijuana, that's kind of the thing they're trying to determine, is that the symptoms, that there's something about the drug that causes that symptom, or is it because the drug is in the system that long and that's why the person continues to have those symptomologies. So that's kind of the questions that are being asked about those. But again, I want to be cautious because there really are no real good studies done on illicit drugs and those kinds of things. And so making sure that when you read those materials that there's a lot of replication is important, because it's kind of hard to tease those out. Now, with that being said, and this is important, if you look at the systems that opioids and marijuana and even severe drug cocaine and those, they all react to that system that as dopaminergic, opioid, and acetylcholine. And again, those are all the chemicals that are associated with the symptomology of schizophrenia. Okay, so that's kind of something to kind of keep in mind, that even anyone can run the risk of taking any of those types of drugs, including alcohol, and end up with these different symptomologies. So I don't know if that makes sense or if I'm just blabbing now.
That makes sense. Yeah.
Okay. Susanna, you have your hand up.
Yes. So my question to you is, um, so would it be safe to say that when a person has used a type of illicit drug for, a long time, and then it starts manifesting symptoms of, hallucinogenic symptoms, or, severely depressed symptoms, aggressiveness, et cetera, et cetera. But then you pair it with, say, jail time when they're incarcerated, especially if they've never been incarcerated and all of a sudden are incarcerated because of their drug use. And they stay there, anywhere from 6 months to however long. Would it be safe to say that it could just worsen the problem when they come out, or not necessarily?
Well, typically, if they're in the prison system, I mean, it's more like, if you want to, it's, even though it's not anywhere close to it, I mean, that's where they are detoxing. So you wouldn't expect them for their symptomology to get worse. With that being said, again, one of the models of schizophrenia and of most all psychotic disorders it is the diathestress model, which suggests the person gets so stressed that they retreat within their mind. And then that starts to produce the symptomology that we commonly see with schizophrenia and other psychotic disorders. So the difficult part about teasing your question out is that they've detoxed, so they don't have that substance in their brain. So did the brain rebound itself? Okay. Did it compensate for the loss of that drug not being there anymore? Or is it because of the stress of the prison system, especially if it's their first time, they're in there for an extended period of time? Was it that stress reaction that then created their symptomology? And that's, again, this is part of the complicated part about this. It's hard to tie those things out. And I do want to just, it is important to recognize that when we talk about overproduction of dopamine and acetylcholine and serotonin and stuff like that, is because of the association it has with the drugs that we use. Okay. The only way to actually measure the amount of dopamine someone has in their brain is post-mortem dissection. Okay, so again, when we say dopamine, overproduction of dopamine uh, is only associated with symptoms, because we can't make that causal remark, because we're only associating the drugs that increase or decrease the level of those chemicals in the brain, and then we see if their symptoms get better or worse. Okay, and so when we talk about things like someone going to prison, for example, is it the physiological detox process, or is it the diathos stress model of being in prison that might be causing the continuation of those symptomology? I don't know if that makes sense, but that's kind of where those kind of, we're not sure kind of questions are at.
I just wanted to add, because I presently deal with an individual, a senior person, and when he was in this a prison, which was supposed to be, they have a like a rehab prison. I didn't know of such a thing, and I think they transferred because he had a nervous breakdown, and I assume it's because he had a lot of fear of being incarcerated, on top of, like you said, maybe he was detoxing, but in his case was crack cocaine. So I don't know how long that stays in your system in the long run. But also he developed like I guess he was already pre-diabetic. He was very thin, but he became worse. And then when he came out, he ended up becoming such a sugar addict that he actually twice passed out eating like a big old thing, a tub of ice cream with chocolate fudge stuff. And when he started easing up on those sugars because of the same, kind of detoxing from that, then that's when the aggression came in, and I saw a lot of changes. And as he ages more, I've seen it get a little worse.
Mm. Yeah, and all those kind of make sense if we kind of look at it, but that's a good example of how these things can have long-term effects, right? So that's a great example. Okay. All right, gang, for the sake of time, I do want to talk about what we're going to get into on Monday. We have a transition kind of disorder called schizotypical personality disorder. This is a delusional disorder. It's a kind of more of a dissociative disorder. But where we're going now is we're going to transition from onset of symptomology that almost, it seems like overnight you wake up and you have this disorder of some type, okay, to what we call personality disorders. Personality disorders are where a person has severe symptomologies that are dispositional within the person. It's probably the most famous one you can think about is someone who is narcissistic or severely self, they think very well of themselves, as you would say. And there's been a lot of literature on on these individuals over the past. But the what we're going to go through is the idea that these, we're going to go from symptomology to dispositional qualities, meaning that this is ingrained as part of the person, which then does another level of intervention that we need to look at. Okay. So, but for the sake of time, because I know we're running late